Welcome to Baby Snugs and Coffee Mugs. I'm Krista.
And I'm Kelsey. We're both labor and delivery nurses from Minnesota. In this podcast, we'll be covering all things pregnancy, delivering in a hospital, and caring for yourself and baby postpartum.
This podcast is meant for educational and entertainment purposes only, so please seek medical advice from your healthcare provider. We are so excited for you to join us, so grab your coffee, snuggle up, and keep on listening.
Cheers!
Cheers! Welcome back, everybody, to episode 14 of Snugs and Mugs.
Welcome, everybody. Last week, we talked about low intervention labor, and this week we want to go a little bit further into it with a special guest.
So with us today, we have a certified nurse midwife that we have the pleasure of working with. We have Amity here. We have worked with Amity for quite a few years now, and she is my own personal midwife. So I'm biased and I love her. If you guys listen to any of our earlier episodes in pregnancy, and one of them, I can't remember which one, I talked about my midwife who made me a baby blanket and was the only one who knew the gender of all of my 3 children. So yes, this is Amity.
Well, thank you for such a great introduction, and I'm so excited to be your first guest on your podcast. Thank you so much.
We are so excited you're here.
We are very, very happy you're here. So thank you so much for being here with us.
Absolutely.
So we are just going to dive right into it then. So we just want to start out by talking about the difference in choosing a midwife versus an OB for your care in pregnancy.
Sure. So first I like to start off with what's similar, because there are some things that are very similar when you choose a certified nurse midwife or an OB. Typically you're going to have the same number of visits, you're going to have the same testing and ultrasounds through the pregnancy. So we really try to practice the same standards of care that way. Some of the other differences though is because we're nurses at heart, we love to teach. And so starting from the beginning of pregnancy, or even earlier if we see you outside of pregnancy, we talk a lot about education, we talk about being healthy, so that you're able to make the best decisions for you during your pregnancy, labor, and birth.
Yes.
Awesome. So unfortunately, not every patient can have a midwife. What would risk factors be that would opt them out of your care?
Good question. And that definitely can vary from practice to practice. So some practices really are ultra low risk, whereas some can take higher risk. So in our practice particularly, we don't see patients that have medical risk factors coming into pregnancy, like high blood pressure or diabetes or a very high BMI. Those are kind of top things. We also don't see patients that have had a previous C-section. That can vary from practice to practice though. And then during the pregnancy, certain things can risk a patient out of our care where they need to then see an OB. Again, if they develop high blood pressure, they have diabetes that requires insulin, there's concerns about fetal well-being like growth restriction. Those are kind of some of the top ones that we see risk people out.
So if you do risk out of being able to getting your primary care from a midwife, is there still options for those who still want to see a midwife in their pregnancy and just not have them be that primary care provider?
Yeah, so in our practice particularly, we do have that model. Now, not all practices have that, but we have it where if you start with a midwife and then you have risk factors that come up, we may then still see you in collaboration with the physician. If you come into pregnancy with risk factors, you may still get to see a midwife periodically through the pregnancy, but ultimately the OB is going to be the one that's your primary care provider, and when it comes time for labor and birth, they're going to be the ones that are managing your care during that time versus the midwife.
Yeah. So guys, for me personally, in my first pregnancy, your guys' midwife care team wasn't quite there yet. And then when it came time for my second, I was planning to see just you the whole time. And then we had a 2-vessel cord, which I think we might have talked about.
I think we did.
I think we did bring this up in a different episode. You guys are learning all sorts of things about me. And so I did kind of risk into having to see him MFM. And then you went on a hike. So I had a different person to deliver anyway, but that's okay. I forgive you at this point. But then for my third one, it was kind of smooth sailing. So I was fortunate enough with my third pregnancy to have the midwife care the whole entire way through and have a midwife deliver my baby, which I absolutely loved.
Wonderful.
So like you said, it's kind of different depending on situations.
And that's actually a good point, that your next baby might be different.
Yeah, that is
Every
true.
pregnancy can be different. We've had patients that see us for one, and then they need to see the OB for the next one, but then the next pregnancy is, kind of going on track. So yeah, each pregnancy definitely can be different.
Yeah. And then there's people like me. So I go into labor wanting an epidural. I am not strong. You guys, we talked about this too. I'm wimpy. I procrastinate and I'm wimpy, right? We talk about this. So I went into it knowing I wanted an epidural. Is that an acceptable thing? Can midwives see patients that are planning a medicated delivery?
Absolutely. Really, it comes down to what the patient wants. So we are here to support what the patient wants. And if she wants an epidural, great, that's fine. Honestly, it's great to know what you want and go into labor, really understanding what your desires and wishes are. And then we can kind of talk about that or prepare for what does a medicated birth look like, or how do you prepare for that? Because that maybe will look a little different. And sometimes we have conversations about what would happen if you don't get an epidural and you do want an epidural. But yes, it does not exclude you from midwifery care at all.
So a patient coming to you that wants an unmedicated birth, what kinds of conversations are you having with them? How early are you starting those conversations?
Good question. So first of all, I start educating patients, really from the first visit. At 12 weeks, I'm typically talking to them about what resources are you using, what books, what apps, what websites, are you using to gain information. And then between 16 and 20 weeks, if a patient really knows they want an unmedicated birth or maybe even aren't sure, I'm going to start talking to them about preparing, because labor and birth and even pregnancy is like a marathon. This is the long haul. Can take a long time, endurance, and it is almost a whole mental game.
Yeah.
We have to prepare mentally for what is going to happen, because sometimes there's turns in the road, it doesn't go as we plan, and we need to mentally be prepared. And that takes time. You can't just decide at 37 weeks, I'm going to do this and I'm going to prepare in 2 or 3 weeks. So because you're also going to need to prepare your support people and gain all of those resources and kind of tools and tips through the pregnancy.
And I feel like on our end, I notice with my patients that are really, really prepared and have done all that research and practice breathing techniques and have all these things set in place, often do better and handle the situation better. And I think more often end up having that unmedicated delivery from at least what we see, I think.
I completely agree. Yeah.
Yeah.
Okay, so kind of transitioning into coming in and laboring at home and doing all these sorts of things. I feel like we talk about early labor a lot. People hear about early labor. So can you describe what early labor is to our listeners, and kind of give them suggestions of what you think is best for them to be doing while they are in early labor at home?
Yeah, absolutely. So early labor is from the time we start contractions until we're probably about 5 to 6 centimeters. And that's kind of the new definition, active labor being 5 to 6 centimeters. And typically in that phase, our contractions are going to be a little bit more spread out. They're not going to be as intense. We're going to be able to relax between them. We might even be able to talk and do activities while we're having those contractions. So unless you're preterm, you have risk factors, or your water has broke, we do encourage you to stay home during that phase, especially if you're wanting an unmedicated birth, because we know that if you get to the hospital in active labor, you're less likely to need pain medication if you don't want it, and less likely to have interventions to help your labor move along. Things that you can do at home during early labor. I always talk about balance between rest and activity. Everybody's like, I'm going to walk this baby out. Yeah. But if you are active for all of those 8, 12, 15 hours and then you get into labor, you're going to be tired. Yeah. So really balancing. Take a walk, go take a rest, take a tub, eat something, drink something. But being in your own environment, you're going to be more relaxed. You're going to be more apt to kind of handle what's happening during that phase.
Yeah, so definitely kind of going towards term deliveries for this one. If patients are earlier than term delivery, does that look different then?
Yeah, we do encourage, if you're before 37 weeks, we want you to come to the hospital to be evaluated, because there might be different things that we need to do because you're preterm, and monitoring baby more and things like that. Yeah, for sure.
Perfect. So say it's not somebody's first baby. Say it's like your second or third baby. What kind of guidelines do you then adjust because it's not their first time doing this?
Yes, absolutely. So we know first baby, the early labor can be longer. So we talk about staying home longer, maybe being a couple hours when you're having those close, intense contractions. Whereas if you've had a baby before, we might say, well, don't wait much more than an hour because most likely that baby's going to come a little bit faster. So kind of guidelines again with first time babies, contractions that are strong. They're lasting a minute every 4 minutes for about 2 hours. And when I say strong, I mean, if I'm trying to carry on a conversation with you, you can't talk to me during that contraction. Those are the contractions that are going to change your cervix. With somebody that's had a baby before, it's going to be closer to like that hour. Or if your water breaks, you're going to want to come at that point once you've started having contractions, because that definitely can speed things up. So yeah, trying to head there a little bit sooner if you've had a baby before.
Makes sense. Yeah. They go a little quicker.
Hopefully, at least. Yeah. That's definitely the hope.
All right. So last week we talked through the admission process, what happens with a patient when they get there, kind of what we do on our end. Is there anything specific that you are doing with them as soon as they get to the hospital?
Yeah, and again, we're going to be evaluating them and their baby and making sure that, everything is going normally. With midwife patients that are low risk, we really try to limit our interventions. So once we know that mom and baby are doing fine on admission, we're going to try to do more intermittent monitoring or intermittent auscultation. We're going to encourage them either to be active or rest if it's still a little bit in the early stage. And then I always just tell people it's kind of an unknown till we get to the pushing stage because we're just going to kind of see how labor goes for them during that point.
So also last week we touched on kind of interventions that we can do as nurses and with the midwife as well to kind of help with your pain and kind of covering your discomfort at that time. So we've talked about, different things we can do, essential oils, all this kind of stuff. So what are your kind of go-tos for your patients in active labor? What do you think is the most beneficial?
I love the tub. Like that is my number one, get them in the tub because I think it really helps people relax. It has shown to decrease the sensation of the discomfort of contractions. The one thing that I would encourage is that people do not get into the tub before active labor is established because it can actually slow labor down in the early phase. So if we're trying to determine if somebody's in labor or they're in early labor for a long time, sometimes we will put them into the tub to help them kind of relax and such. But if you're in active labor, get in that tub, try to spend some time in there. Other things that I really encourage are frequent position changes. So positions that I like are positions we can get the belly under us. So hands and knees, sitting on the ball, leaning over the bed, things like that. So during the process of labor, the baby needs to make turns through the pelvis. So the pelvis is oval in shape on all of the different parts of the pelvis. And then the baby's oval. So it can't just bloop, go right through. It has to turn through that. So the more we can keep mom moving through labor, the more likely we're going to help facilitate baby's movement through the pelvis.
Yeah, exactly.
All right. Then following active labor, you start transitioning. What does transitioning look like?
Transition is that crazy, I want an epidural, I don't want to do this anymore stage. There's
this baby out of me.
Right, exactly. It's very rare we don't hear some of those, pleas for help or I can't do this. People are like, I hit the brick wall. That's typically when we're closest to the end. And we're, usually 8 or 9 centimeters. Contractions are really intense. They're coming quickly. We kind of see some of those signs, maybe shaking or nausea, but it's when we're the closest. And so that kind of brings us then to actually the pushing stage, which most people, and myself included, say once I got to that point, those contractions felt totally different because we're focusing all of our energy on pushing. And people just are like, I didn't sense it the same as I did before that. And now we've got this focus, this goal of pushing our baby and using those contractions for pushing.
What do you think are the benefits of pushing if you don't have an epidural, if you have a little more freedom?
Yeah, for sure. So first of all, we kind of know where to push. So without an epidural, we have the sensation of where to push, when to push. We're not having somebody, need to tell us, okay, you're having a contraction and push. Without an epidural, we're more able to change positions, get into positions that can really help. We often see women without epidurals finding positions like hands and knees, sitting on the toilet, side lying. But we still encourage people to move, continuously moving. We have a birth chair at our facility, and the birth chair is a great place to birth. I do encourage people not to spend a long time just sitting on the birth chair, because if you sit there for a long time, you can actually have edema in your perineum. So we want to kind of push in various positions and then maybe save that for the very end when we're actually birthing our baby.
Yeah, so baby's coming out. What does that process look like on your end?
Yeah. So depending on position, so I tell people I've literally birthed with women in all positions.
Yeah.
So standing, kneeling, sitting on the toilet, hands and knees, side lying, all of the different positions.
Seen them all.
Yeah, I literally have seen them all, I feel like, at this point. But somebody will prove me wrong.
Next week it's going to happen. Yep.
So for me, then once baby, is close to the end, it's really important to listen to the midwife that's helping you, because we want to help that slow entry into the world. So we're helping those tissues stretch. We don't want to just push with all of our might and baby kind of comes flying out, because we can have more damage to the tissues. And then once baby comes out, I'm going to put baby right up on the abdomen and the chest. And then we can do suction and stimulation if needed. So I like to kind of have that transition right from the perineum right up on the chest, because that's where I want baby to end up. And that's where we can help baby and, again, dry, stimulate, suction if needed. So we can transition right into like breastfeeding if needed. Skin to skin is, again, kind of one of those goals in that really immediately right after baby is born.
Yep. So the nurses are usually kind of doing vitals on the baby and kind of helping the mom with that kind of stuff, while you guys are kind of still waiting for that placenta to come out. Yep. Typically we give Pitocin to all of our patients after delivery. Do you want to kind of discuss that a little bit? I feel like sometimes people either have not heard that that's a common practice. Just kind of touch on that.
Yeah, and we really try to talk to patients about that in the office, so they kind of understand what's happening during that immediate postpartum process, because so much is happening. They might not remember that we've talked to them about that, so we talk about it in the office, then we know, their wishes and desires. Pitocin after the baby is born is important because it actually helps the uterus contract down, reduces the risk of postpartum hemorrhage or the amount of blood that we lose after the baby is born. So, correct, then we deliver the placenta, and that can take anywhere from minutes to up to a half an hour.
Yep.
We try to be patient through that process. Sometimes breastfeeding can help, facilitate that. We also are looking for any tears that could possibly have happened, and then any suturing of those repairs that we need to do during that time.
Which they will numb you guys up. So
for sure. So if you've not had an epidural, we will put lidocaine in those areas. Yes, you do not have to suffer through that part.
I think that would be the hardest part after, I just feel like it would be so uncomfortable. You just push the baby out and I know you guys numb people up, but I feel like it's tough.
It is hard, and I think it's hard on our end too, because we know how sensitive all of that is, and we do our very best to try to be as gentle as you possibly can with that procedure.
Yeah, exactly. So then kind of the rest of that postpartum phase. So we have an episode kind of talking about what we do, but for the rest of your patient stay, what's your role then?
Yeah, good. So again, after kind of that initial stage, we've got everything fixed up. We help get mom cleaned up, kind of get her back together. And that's kind of where that initial kind of hands-on role stops, because the nurses are going to be the ones that are helping you with breastfeeding. They're going to be checking your tummy, your fundus. They're going to be kind of the ones caring for you during that time. And then each day during your stay in the hospital, hospital, we're going to come and see you and see how you're doing, provide some education, and then preparing you for discharge by giving you information about what to be watching for, what to be doing in the early postpartum phase, and then scheduling appointments. So our first-time moms, we see them either virtually or in the office at about 2 weeks, just to kind of do that early check-in, make sure they're doing well. And then anybody that might have risk factors, we're going to see them early. And then we're going to see everybody at 6 weeks postpartum.
So it might be different wherever you guys are getting care, but always ask before. We always try to tell you guys this. The more education you have before, the less you have to remember after you just had a child. So, yeah.
All right. Last question. What's your favorite thing about being a midwife?
I love being there when babies are born. Honestly, it's just the best part, because it's just such a wonderful time bringing this, helping bring this, baby into the world, and seeing the excitement and the joy on the parents' faces as they're meeting their baby for the first time.
Yeah. I agree. I love that part too. And they're all so different.
It is. I mean, there's no two births that are the same, even though there can be similarities.
Yeah.
They're all unique. And every time the baby comes out, I'm like, how did it fit in there?
Right?
In my brain. Every time.
Like, hold them up afterwards. You're like, how did that happen?
It's just amazing.
Oh, fun. Yeah, I mean, I think all around we can say that we have a pretty great job. So thank you so much for answering all of our questions. I think that wraps up our questions. So unless you have anything else to add.
I do have one thing.
Okay.
So I'm going to be launching my own podcast called Midwife Musings, where we're going to kind of get a little bit more in depth about probably like midwife topics. We're going to be talking about kind of medical type of things, although practice things too. So what's the day in the life and week look like for the midwife? We're going to talk about cervical ripening. I don't have all the lists yet, but we're going to be hopefully launching that in the near future.
Yay, exciting.
That's so exciting.
We will definitely be listening.
Awesome. Sounds good. I love
We can share with you guys too as soon as we find out.
Great. Sounds good.
So yeah, thank you so much for being our first guest. We are more than honored to have you here with us.
Thank you.
Well, I'm honored to be your first guest. So Thank you so much for having me on with you guys today.
Welcome. And thank you everybody for listening to us once again. And we will be back again next week.